The topic is traumatic brain injury, also known as TBI. TBI is one of the top 5 leading causes of death and disability in both adults and children. TBIs can be classified as either open or closed brain injuries. A closed brain injury is injury to the brain without any break in the skull. Open is where you have brain injury with penetration or break in the skull. A TBI can result in temporary or permanent brain damage. Temporary damage would consist of an altered level of consciousness that would resolve itself. Permanent brain damage can result in cognitive, physical, and psychosocial impairment for the remainder of their life. There are various types of brain injury. These all can stand alone or they can be in combination of each other. Let's explore each of these individually. A concussion is a mild form of a TBI. This is where the client sustains a mild blow to the head, such as being hit in the head with a ball. There will be a brief or no loss of consciousness. The client will sustain symptoms such as headache, dizziness, or a period of amnesia, forgetfulness. But on a CT scan, there will be no evidence of brain injury. And typically symptoms of a concussion will resolve themselves within 2 to 3 days. If these symptoms are lasting longer, the client should reach out to the healthcare provider. A contusion is a bruise of the brain. This is a very localized or focal area. And because of that, the symptoms will vary depending on the location in the brain. Another type of brain injury is known as a diffuse axonal injury. This is where there's profuse cerebral edema. If we imagine our 2 hemispheres coming together in our brain, when a client sustains a high-speed motor vehicle collision, for example, their head and brain are rocked back and forth, and this causes shearing of those hemispheres. This directly affects the white matter. White matter in our brain is what connects our right side to our left side brain in communication and function. This leads to diffuse brain swelling, and there is a high mortality associated with DAI. If the client does survive this injury, they are oftentimes left in a persistent vegetative state. Another type of brain injury is caused by a skull fracture. Now, our skull is a bone. In the world of orthopedics, we define or describe the type of fracture. We do the same thing with a skull fracture. Common types of fractures to occur here are linear, which will follow the suture lines of the skull. Depressed, meaning that a piece of that skull bone is pushed down. Another type is comminuted, which means that the bone has shattered into small pieces. All 3 of these types of fractures can impact the underlying brain tissue and cause brain damage. There are also types of hematomas or bleeding that can occur at various levels within the brain: epidural, subdural, and intracerebral. Intracerebral means deep within the brain tissue, we will have bleeding occur. We will talk about epidural and subdural on upcoming slides. Symptoms associated with TBI are due to brain swelling and high intracranial pressure, also known as ICP. Symptoms that the client may display are nausea, vomiting, worsening headache, an increase in drowsiness, or in other words, a change in their level of consciousness. This also may be exhibited in changes in their behavior. They may become more irritable, angry, or forgetful. We may see motor and sensory deficits. When one side of the brain is affected, the opposite side of the body will be symptomatic. In other words, we may see left-sided brain trauma and right-sided weakness or deficit. We may also see vision difficulties. Remember, when there is brain swelling going on, this affects our cranial nerves that then innervate our optic nerve. We can start to see blurring or changes in vision. We can see photosensitivity or sensitivity to light. Along with that, we will see pupillary changes, dilation, constriction, and this may be seen unilaterally or bilaterally. Because of the increased swelling and damage to the brain, this causes the client to be more susceptible or at risk for seizure development. A CT scan of the brain will help determine the severity and type of brain injury that we have. When a client has sustained a skull fracture, there will be some unique findings. Depending on the location of the skull fracture, The client may exhibit battle sign, which is bruising or ecchymosis noted behind the ear in the mastoid region. If the skull fracture is more towards the anterior portion of the head, you may see discoloration around the eyes, known as raccoon eyes. With skull fractures, there is an increased risk that the frontal bones, also known as the sinus bones, could become fractured. When sinus bones are fractured, this now leads to a pathway for cerebrospinal fluid, known as CSF, to leak out. Two places that we may see this leakage is through the nose as well as through the ear, as you can see in our illustration. Normal CSF fluid is a clear color, but because of the trauma and the bleeding that may be going on in the brain, this may have a reddish tinge to it. Let's talk a little bit more about specific types of bleeds. The epidural hematoma. This is blood that accumulates between the dura mater and the skull, so it's up near the surface. This is caused by arterial bleeding. Because this is an arterial bleed, there will be a rapid change in your client's neurological status. This is an emergent situation, and surgical evacuation will need to take place. An epidural hematoma is noted in the illustration to your right. Let's take a look at a subdural hematoma. This is when blood accumulates between the skull and the brain. This is caused by a venous tearing and bleeding. As you can see on our illustration on the right, this is an example of a large number of veins that were affected and is causing an acute bleeding episode. This is where you will see symptoms and neurological changes in your client that appear rapidly. Depending on the number of vessels involved, we may see a slower bleed or a slower onset. This could lead to either subacute or chronic subdural hematoma. The tool that is used to evaluate and monitor a client's neurological changes is known as the Glasgow Coma Scale, the GCS. This tool evaluates three areas: eye opening, verbal response, and motor response. A score is then given according to what is observed. As you can see from the illustration, point values are given for the patient's response to each of those three categories. Those points are added up and a total score is given. This determines the severity of the TBI. As you can see from our illustration, mild, moderate, and severe are now categorized. When initially caring for a client with a TBI, it's important that we include cervical spine stabilization. The head and the neck are very closely related. We never want to assume that it's only just the head that's involved. Using a hard collar to stabilize the cervical spine will be necessary until radiologic studies have been completed. We will monitor the client for increased ICP. Monitoring for those neurological changes. What was baseline? What's different? Application of oxygen will be important. Perfusion of the brain, both healthy brain and damaged brain, will require oxygen. We want to make sure that we have 2 large gauge IVs for crystalloid administration, such as 0.9 sodium chloride. We also want to make sure that we maintain normal thermia. Not too hot, not too cold. We don't want the client sweating or shivering, as both of those can increase ICP. When a client has a GCS score of 8 or 9 or less, there is a likelihood that there is difficulty maintaining a patent airway. Endotracheal intubation will be required with ventilation support. Pupillary assessment will be important. Monitoring size and reactivity to light will be documented and trends will be monitored. Make sure that we are monitoring for any CSF leakage from both the nose and/or the ear. Serial CT scans will be performed to monitor the client's condition. Based on the results of the CT scan of the brain, the client may require neurosurgical intervention. This may also require the placement of an intraventricular catheter to monitor the ICP. We will want to make sure that the head of the bed is elevated at a minimum of 15 degrees to 30 degrees at all times, unless contraindicated because of a spinal injury. We want to make sure that the head is positioned midline. We don't want to see any flexing or bending of the neck. This will impede blood flow, and we need that essential blood flow that's carrying oxygen to the damaged portions of the brain, as well as the part of the brain that's not damaged. We may see the administration of medication to control increased ICP. This is known as mannitol. It is an osmotic diuretic. This will pull fluid from the brain and into the systemic circulation, where it then will be eliminated. The nurse will also monitor and want to prevent complications. Seizure activity is something that we'll be monitoring for because of the acute brain injury. Fever and infection will increase metabolic rate, which will increase ICP. Additionally, the nurse will monitor for deep vein thrombosis, known as a DVT, and the development of a stress ulcer. A craniectomy may be performed. As you can see on our illustration to the right, the neurosurgeon has removed a piece of the skull. The neurosurgeon will sew the skin back in place until a later time when the bone can be replaced. When caring for the client after a craniectomy, it is important that the nurse does not turn the client onto the operative side. There is nothing to protect that soft spot. Turning the client from their back to the non-operative side is what's recommended. It is important that the nurse accurately document the amount of drainage, as well as monitoring the dressing for any signs of additional drainage or signs of infection.